first of all يعني it's always a pleasure المؤتمر بتاع الاسم بتاعنا it's our honor I hope ان احنا نفضل دايما مع بعض وبشكر ايرس وبشكر AstraZeneca for giving me the chance to talk about this subject. I'll start sharing my screen. Okay, so I know they are giving me 15 minutes and we are already late on time, so I'll try to be as fast as and effective as possible. So I'm going to talk about management of locally advanced unresectable non-small cell lung cancer. And as you expect, most probably my emphasis will be on immunotherapy role. This is my disclosure. So, talking about the majority of lung cancer are diagnosed as unresectable stage 3 or stage 4 non-small cell lung cancer. We know around 25 to 40% of patients of non-small cell lung cancer present with locally advanced disease. Approximately 30% of the patients present with locally advanced disease, stages that are mostly unresectable. The ISLC patient database provide expected outcome according to tumor stage from the 8th edition of the TNM classification, averaging for a clinical staging for a 5-year overall survival from 36% down to 13% for the stage 3 non-small cell lung cancer. When we talk about unresectable stage 3 non-small cell lung cancer, our evolution of treatment passed into attempts to go from radiotherapy versus sequential chemotherapy and radiotherapy, and then proceeding to radiotherapy versus concurrent chemotherapy / radiotherapy, and then we start challenging the sequential versus concurrent chemotherapy radiotherapy. However, with median PFS with concurrent chemoradiation therapy is approximately around 8 to 10 months, and only 15% are alive at 5 years. One of the studies, just an example, was a randomized phase 3 trial of pemetrexed cisplatin or etoposide cisplatin plus thoracic radiation therapy followed by consolidation chemo in locally advanced non-small cell lung cancer, the PROCLAIM study. In this study, as expected in most of the trials in this setting, we find a median PFS of 11 months and a median overall survival of 26 months. This is a review of the most important studies that have been done in the past 10 years that failed to modify or improve a standard of care concurrent chemoradiotherapy in patients with unresectable stage 3 non-small cell lung cancer. Starting from the KLHGP 39801 with induction therapy prior to concurrent chemoradio increased toxicity and didn't prolong survival versus concurrent chemoradiotherapy alone. PFS was 7 versus 8 and 12 versus 14 months. Also, the HOG USO in 2008, the consolidation docetaxel increased toxicity and didn't improve survival versus concurrent radiotherapy alone. The SWOG S0023 attempt to add gefitinib consolidation in an unselected patient population was an absolute failure. It actually decreased survival versus control arm. In the KCSG LU0504, the consolidation docetaxel plus cisplatin didn't improve survival when added to concurrent. The RTOG 0617, the addition of cetuximab to concurrent chemoradiotherapy didn't improve survival versus concurrent chemoradiotherapy. Well, even if there were some numerical advantages, but it never reached any statistical significance. The KLGP 30605, the addition of erlotinib to radiotherapy, provided no significant survival benefit over radiotherapy alone after induction chemotherapy. So the studies most probably wasn't really exciting as an outcome. The effect of previous radiotherapy on survival was observed starting from the first Keynote 001, one of the first Keynote study in any or extracranial radiation therapy. This observation showed that the survival and the outcome received radiotherapy has a ratio of 0.58. So how come the chemoradiotherapy, you can hear me well, right? I think you can hear me.
Yes.
You can hear me well, right? Yeah. Okay.
Now, yes.
So how comes yes. So how comes the chemoradiation sensitize the tumor to immunotherapy mechanism of action? So chemoradiation therapy causes induction of tumor antigen release, and this stimulates adaptive immune response and PD-L1 upregulation. And PD-L1 overexpression leads to immune cell invasion and T-cell inhibition. This gives immunotherapy in this setting, durvalumab, better targets and more targets to block PD-L1 and restoring T-cell functionality and reversal of immune suppression leading to systemic anti-tumor response. So studies of IO in combination with concurrent chemoradiotherapy in inoperable stage 3 non-small cell lung cancer. We have a lot of studies. This is a big table, but when you look at them, there are not a lot of stage 3 phase 3 studies, mainly the Pacific we're going to discuss, and the HCRN LUN 14179 for the concurrent chemoradiotherapy followed by pembrolizumab, also we're going to discuss. Most of other studies are small studies and some data are not yet mature. So the Pacific study, this is a phase 3 randomized double-blind placebo-controlled multi-center international study was for unresectable stage 3 non-small cell lung cancer without progression after definitive platinum-based concurrent chemoradiotherapy at least 2 cycles. All comers population, irrespective of PD-L1 status, was also included. Number of patients was 713 patients. Randomized to durvalumab 10 milligram per kg every 2 weeks for up to 12 months for 176 patients, and placebo 10 more or less the same was 237 patients. Primary endpoint was the PFS and overall survival. According to the Pacific selection criteria, at least 2 prior cycles of platinum-based chemotherapy containing whatever kind of approved chemotherapeutics. However, the patient should receive the last radiation dose before starting. Initially, it was from 1 to 14 days before randomization. However, it changed up to 42 days through a protocol amendment. The Pacific baseline characteristics, the intention to treat population included all settings, but you will find here quite a nice number from stage 3A and stage 3B. We find all tumor histologies, squamous and non-squamous. We find previous chemotherapies, either in adjuvant or in induction or in concurrent. We also find the PD-L1 status difference, so divided into more than 25%, less than 25%, and quite 36% of unknown setting. The 3-year overall survival update from the Pacific. In the end, I will present the 4-year survival data also, but starting with the 3-year overall survival, the hazard ratio is 0.69, and with the 36 months overall survival was 57% versus 43%. So we're reducing 30% reduction in the risk of death for the median OS was not reached actually in durvalumab arm. Also, one thing that you should observe that the PFS was calculated up to 6 weeks after concurrent radiotherapy. So when we take about the PFS for concurrent chemoradiotherapy is around 10 months, so we are actually calculating it from the beginning of the concurrent chemoradio. When we talk about the PFS for the Pacific, we are actually starting the calculation of the PFS from the start of randomization of the Dorvo, which most probably is more, it can be over 6 weeks after concurrent radiotherapy. So this are more or less 6 weeks of concurrent chemoradiotherapy, 6 weeks median till you start. So there is almost 3 months that can be subtracted from 8 to 10 months of the classic median PFS for the concurrent chemoradiotherapy when you try to compare the added value of the durvalumab. So when you do as updated progression-free survival in the intention to treat population, the PFS hazard ratio was 0.51, and the median PFS was 17.2 versus 5.6 for the placebo. The progression-free survival and the overall survival for the subgroups, all on the left, clearly stating the benefit and the advantage of using durvalumab versus giving nothing or placebo. The post-hoc exploratory pre-concurrent radiotherapy PD-L1 subgroup analysis, this was actually done following a health authority request. So they required post-hoc to analyze the PD-L1 status for the placentas. That was not initially required. However, from the 713 patients, only 545 have tissue, and from those, only 451 was evaluable. So only 63% of the patient populations in this study was assessed for PD-L1, either less than 1% or more than 1%. So according to this subgroup analysis, PFS was still consistent in both PD-L1 status, either by 25% subdivision to above and below 25%, and the post-hoc, which is like less than 1%, more than 1%. However, the overall survival was not achieved in the PD-L1 status less than 1%. But there are facts that you should observe when you try to analyze this information, because the PD-L1 testing was not actually required. So 37% of the patients who were actually included in our data analysis of the intention to treat population was not added to this analysis. The PD-L1 status was obtained pre-concurrent chemoradiotherapy. So the effect of the concurrent chemoradiotherapy on PD-L1 status was not actually feasible to assess. PD-L1 expression level cutoff value of 1% was part of unplanned post-hoc. So this was statistically, this is just a post-hoc analysis requested by a health authority. The updated time to death or distant metastasis also was an advantage for the durvalumab, 28 months versus 16.2 months, which has a ratio of 0.53. Again, the anti-tumor activity in the intention to treat population, the durvalumab was 28% versus 16%, and duration of response was not reached for durvalumab versus placebo was 13.8. The second progression or death for the intention to treat population was also advantageous for the durvalumab with a PFS2, 28 months versus 17.1 months for the placebo arm. Talking about the updated safety summary, so things that led to discontinuation, we find 15.4% only toxicity that led to discontinuation in the durvalumab versus 9.8% in the placebo. Any grade pneumonitis / radiation pneumonitis was 33% for the durval versus 24% for the placebo, and the grades 3 and 4 was 3.6% versus 3% for the placebo. The post-discontinuation disease-related anti-cancer therapy for the durval arm versus a placebo. So 41% of the patient who was on durval received subsequent anti-cancer therapy versus 54% for the placebo. The radiation therapy represented 17% of them. 8% took immunotherapy again, and 26% cytotoxic chemotherapy, and 9.9% was systemic therapies. The most frequent adverse events was actually cough, pneumonitis, and fatigue. So this is one of the most important things to assess. And in conclusion, durval demonstrated statistically significant and clinically meaningful improvement in OS versus placebo in the intention to treat. Hazard ratio is 0.68, with improvement in PFS, time to disease progression, incidence of new lesions. So Pacific Mini was the first study to demonstrate a survival advantage in this subset. Another study, the last study I'm going to talk is about the consolidation pembrolizumab following concurrent chemoradiotherapy for unresectable stage 3 non-small cell lung cancer, the LUN 14/179, with concurrent chemoradiotherapy with etoposide cis, paclitaxel carbo, or pemetrexed cisplatin, and 59 to 66 grades. So, and then they repeat imaging from 28 to 56 days later. If progressive disease, they are out. Stationary disease or respond, they will be started in pembrolizumab up to 100 milligrams every 3 weeks. This is the phase 2 study, if you want to emphasize. Patient and disease characteristics, more or less, they are equally from different kinds of chemotherapy was introduced. consolidation chemotherapy was only in 4%. PD-L1 status, there are all number of the patient was 92, so 11%. 11 patients were actually PD-L1 negative. The progression-free survival, the median progression-free survival was around 17 months. So in total, this is more or less the data we have in this setting of consolidating concurrent chemoradiotherapy in stage 3 non-small cell lung cancer, with the data with Dorvo is clearly advantageous for the patient, improving OS and PFS. In the last ESMO 2020 Congress, the data for the 4-year survival update was announced, keeping with OS has a ratio of 0.75. An advantage was 49.6% of the patient on durvalumab was surviving at 4 years versus only 36% on the consolidation. And regarding the PFS, the hazard ratio was 0.55, with 35% was progression-free at 4 years versus 19.5%, with a median progression-free survival of 17 months versus 5.6 months only. And updated OS and PFS in pre-specified subgroups was maintained. No clear differences was observed according to different subsets, but all consolidate the benefit that you get with the addition of Dorvo as a maintenance or consolidation approach following the concurrent chemoradiotherapy. And thank you.
Thank you, Professor Amr, for your excellent presentation as usual. But sorry for the delay in the schedule. We don't have time for questions. And so we will go directly to the next session. Thank you so much. It was simple and clear. Thank you so much.